everyone to this recording of OMIC's Bruce Spivey MD Forum. We pay tribute to Dr. Spivey every year for the role he played in creating OMIC. This year's topic is office-based surgery, and I'm really pleased to be joined by two physicians from our board. First, Dr. Daniel Briceland is the chair of OMIC's board. Welcome, Dr. Briceland.
Thank you, Anne. Happy to participate.
And I'm also joined by Dr. Daniel Berinstein, who is the chair of OMIC's Office-Based Surgery Task Force. Welcome, Dr. Berinstein.
Thank you, Anne. Happy to be here.
So Dr. Berinstein is a covalent shareholder. We're all affiliated with OMIC, but otherwise have no financial disclosures. So why devote our forum to office-based surgery? When I asked Dr. Briceland to join me on the panel, he chose this topic because of the discussions that have been happening about performing intraocular procedures in an office setting. We know that oculofacial plastic surgeons have been performing a wide range of procedures in their office for some time. The interest in cataract surgery in the office is in part prompted by CMS looking at possibly paying for this. So OMIC has spent a couple of years exploring this. Our board appointed the task force, which, as I mentioned, is chaired by Dr. Berinstein. Other members included Drs. Ho-Sun Choi, Rob Fonte, and Laura Fine, and I was privileged to join them in this work. We put together a survey that we sent to all OMIC policyholders, and two key findings from the survey was that COVID seems to have put a damper on building cataract surgery office suites, but just this week, a couple of articles came out in Review of Ophthalmology on this. The other surprising finding was how many insureds are worried about moving what we termed ASC surgeries into the office. They asked us to propose recommendations, and I'll be presenting those at the end of the talk, and these were reviewed by the task force. Let's take a look backwards for a second about paid office-based surgery claims. I found 34 payments. And obviously, this is a very small percentage of our claims and payments, but they represent significant patient harm and liability exposure. Here are the procedures in these 34 claims, and you'll notice that skin procedures are the most common. We won't be presenting any cases from that because the issues were either that the physician didn't have enough experience with the equipment or procedure, or the staff member to whom it was delegated was not adequately trained or supervised. So instead, we're going to look at three other of the surgeries. If we look at the payments we've made, you can see that the mean and median payments are quite comparable and significant. The highest payment is a case Dr. Briceland will be presenting, which cost $1.2 million. That compares to our highest ever claim of $3.375 million, which was an ROP case. But this $1.2 million payment for an office-based procedure was one of only 6 payments over $1 million in our entire history. I'm now going to pass the baton to Dr. Briceland. I mentioned he's the chair of our board. You know him from any number of many important functions he's fulfilled for the Academy, and he's a comprehensive ophthalmologist practicing in Arizona. Dr. Briceland, go ahead and present your first case.
Thanks, Anne. As Anne mentioned, this is really a timely topic. Office-based surgery is here to stay, and there's no question its numbers will increase. And it will certainly be a topic of discussion for many years going forward. And OMIC will continue to address this probably in multiple task forces as things change. Certainly, it was interesting too with the task force, some of the outcome, given the whole angst and issues with us during the COVID shutdown. You know, a lot of physicians had a lot of time to think about these things. And I believe actually if we did this survey again in a few months or 6 months, it probably would be significantly different. So this will be an ongoing discussion. So we presented some cases that were obviously interesting. So it's certainly not consistent with the thousands of other cases that occur throughout the year, but I think you'll enjoy some of these two. Next slide, please. So this is a case, eyelid case of a 69-year-old male who has a professional degree. He's referred to a well-trained oculoplastic specialist for which we hear quite often in a comprehensive geriatric practice like mine, droopy eyelids. Vision at that time was 20/30 in both eyes, and the external and internal examination was relatively normal. And he had a classic case of a moderate ptosis with dermatochalasis. So the office did what was certainly appropriate, a thorough preoperative workup. Consent was obtained by the staff and was complete, including loss of vision and hemorrhage. So 3 days later, the insured performed a ptosis repair, a bilateral ptosis repair, upper and lateral lower blepharoplasty, and browpexy in both eyes in his office surgical suite. The operative note notes no complications during the surgery. Next slide, please. So in the post-op area of the office surgical suite, about 20 minutes later, in fact, the surgeon was reviewing some of the post-op instructions with the spouse, and there was noticed to be a fullness in the left lower lid, and it was noticeably different at that time than the right lower lid. They put a little bit of pressure, inspected the wounds briefly in the post-op area, and during that time, as he did that, using some ice packs and light pressure, the blood pressure went up from 125/86 to 145/115. Next slide, please. So the surgeon brought the patient back to the office OR, and released the sutures, both the skin and canthoplasty sutures, and put more pressure, more ice on, and carefully watched that for a good 20 to 30 minutes and manage some of the pressure issues. When the intraocular pressure, when the systemic blood pressure went down to normal, the surgeon felt the wound was adequately controlled. There was no evidence. He actually did a careful inspection of adequate arterial bleeding anywhere, just more oozing. When the blood pressure went down, he felt the oozing was down significantly and sufficiently enough that he could repair the wounds. So he went ahead and repaired the skin wounds, including the canthoplasty. However, it was too tight on the right side to completely repair that, so he left the right canthoplasty wound opened. The surgeon then discussed with the spouse and the patient some of the issues to watch out for, and suggested a return to the office in 2 to 3 days for additional surgery. Next slide, please. So after about an hour plus long drive home, where this patient lived away from the surgeon's office, in fact, it was about immediately upon arriving home, he noted significant vision loss in his left eye. He called the surgeon, and he's obviously suspected with the earlier oozing hemorrhage in the eye, and he referred him to the local hospital emergency department for evaluation. He did call the hospital in advance and let the hospital know the patient was coming in, discussed with the ER physician at the hospital. So when the patient arrived, the ER physician did diagnose a left orbital hemorrhage. He released all the sutures, including the canthoplasty, and noted significant vision loss in the left eye at that time. The patient had a CT, which noted significant orbital hemorrhage on the left side. The patient was admitted to the hospital by one of the local general surgeons. Next day, post-op day 1 at the hospital, the surgeon went to evaluate the patient, and at that point in time, over the course of the evening, noted adequate hemostasis, and a lengthy discussion with the patient, and they decided to take the patient back to the OR at the hospital for a revision of bilateral upper and lower lid wounds, which were hissed after the ER physician removed all the sutures, including the canthoplasty sutures. And this was done, interestingly, under general anesthesia. Next slide, please. So, and this is post-op day 2 from the original surgery. He was discharged from the hospital. And fortunately, the surgeon was able to find a local ophthalmologist to help in his care. And he was followed daily by a local ophthalmologist over the next 3 days, who continued to note no light perception as a vision in the left eye and a gradual improvement in the swelling daily as he evaluated the patient. On post-op day 7, the patient returned to the surgeon's office, and he noted at that time vision was 20/60 in the right eye, continued to be no light perception in the left eye. He flushed the wounds, carefully inspected the wounds. Next slide, please. And performed bilateral lateral canthoplasties to close the residual part of the wounds that were still open. And that was done without any complications, and the patient was discharged to home, where again he was followed briefly a few visits by the local ophthalmologist, who each day noted improvement in the chemosis and swelling, and the canthoplasties remained intact. Next slide, please. 2 weeks post-op, the surgeon evaluated the patient, and at this point in time, the swelling was down to near normal, and he had a residual leptosis, wasn't completely even with the right eye, and he recommended a revision of the leptosis, but at that point, the patient preferred to wait, and the patient preferred, after he was discharged, there was no further visits at the surgeon's office. Over the next few weeks, he occasionally saw the local ophthalmologist, and after about week 4, he noted that vision was 20/20 in the right eye and continued to be no light perception in the left eye. Both eyelids, in terms of edema and swelling, had returned to normal. Next slide, please. So in this particular situation, the plaintiff expert opinion was some of the major concerns they had. There was no procedure-specific consent. The consent was more general for some of the eyelid ptosis procedures and didn't really go into enough detail. The plaintiff's physician felt that there was not enough time, adequate time for the anticoagulant to be recovered, or it was only 5 days after the stoppage of aspirin. And most importantly, the plaintiff's expert opinion said that he failed to recognize the compartment syndrome, which was likely the cause of his no light perception vision, where severe hemorrhage and or swelling can lead to the ultimate poor visual outcome. And lastly, they felt there was some not enough attention to detail in the postoperative course, given the difficulties that occurred during the surgical procedure itself. And in other words, the patient was told to come back in 2 to 3 days. Next slide, please. So in some of the defense expert opinions, and these were all done by oculoplastic surgeons, one expert opinion felt that the surgical complications were not particularly uncommon and not necessarily negligent. And as I said earlier, the surgeon did do a thorough initial workup. And he also, upon discharge after surgery, did a thorough evaluation, including an indirect examination to make sure there was adequate arterial flow in the fundus. But, the other opinions felt differently, including, as I mentioned earlier, from the plaintiff's expert opinion that there was poor management of the anticoagulant therapy on aspirin. It should have been stopped, according to one expert opinion, of at least 10 days, preferably 14, and not the 5 days that occurred in this case. Additional comments by some other oculoplastic defense expert opinions where the post-op management of hemorrhage and swelling was misguided due to the lack of recognition of compartment syndrome causing the ultimate poor vision loss. For example, when the surgeon evaluated the patient in the 20 minutes after the original surgery, which was the original day of surgery, he went back and he closed the incision in the left eye, but left the right, canthoplasty incision open, as well as some of the skin sutures open. So there was some confusion over the expert's opinion of why he didn't leave that open in the left eye as well. Interesting thoughts by the expert opinions. Next slide, please. So And with this claim outcome, as you can see, the case settled for $2.2 million, which for an ophthalmology claim is pretty much off the charts. It's a very high settlement. And in this case, it was a 69-year-old retired individual with a professional degree. And it was kind of hard to argue with the permanent loss of vision in the left eye. But you can see that it was a really serious amount that indemnity payment for OMIC to pay, and ultimately, the defense attorneys felt like they really couldn't defend this case given some of the expert opinions that you heard earlier. Next slide, please. So some of the key takeaways, certainly the pre-operative evaluation is vital, and in this particular case, it would be regarding the medical issues. It really is important to take the time. If you're going to be in an office-based setting, you're the captain of the ship. You need to handle, all these issues, particularly in this situation regarding the anticoagulation, hypertension, or any other cardiac issues need to be addressed ahead of time. Whether that requires a second opinion from the patient's PCP or a family practitioner is really something I think needs to be determined well ahead of time. Preparation for complication management is super important. I mean, in this case, again, with the hypertension and the oozing and the arterial loss of blood, just those management of those types of situations need to be well thought out in advance, and a patient probably should not be discharged too early. And as in this case, was done after 30 minutes or so after the second surgery in the office-based OR. And then I think it's really important to collaborate with local hospitals and or local ophthalmologists ahead of time if you are going to be discharging patients that are clearly an hour away or further, to make sure you can handle any instances of complications, which certainly can and will occur. Next slide, please. So that sort of a nutshell of a very serious case of eyelid surgery. As I said earlier, the many eyelid surgeries perform very safely in the office-based setting, but that one certainly is something to think about. This is a brief case, won't be as long as the last case, but also very interesting on pterygium surgery. Next slide, please. In this case, there was a 42-year-old with chronic redness, chemosis, and swelling. And this patient was also referred to a cornea specialist for some of these issues. And in this particular situation, the vision was 20/20. Pre-op was diagnosed and confirmed as a pterygium, and a full workup was performed, appropriate workup at the office. 2 months later, the surgeon performed a pterygium removal with graft. Next slide, please. The case, according to the operative report in the office, was uncomplicated, and patient was discharged. But on post-op day 1, patient complained of pain and diplopia. He had a very significant esotropia, and the exam was consistent with lateral rectus muscle transection and loss of membrane graft. Next slide, please. So, certainly in the patient's, in the surgeon's office, there isn't a lot you can do in a situation like this. So the surgeon examined the patient, found that, there was this required a strabismus specialist, and he urgently referred this patient to a strabismus person in the local area at the university, who diagnosed a lateral rectus tendon slippage. And surgery that day was performed, an exploratory strabismus surgery to reattach the lateral rectus muscle. And a final vision of 20/20 resulted with no diplopia or prism necessary, which is ultimately, obviously, a great outcome. Next slide, please. So in this case, the plaintiff's expert felt that there should have been some medical treatment first, that this patient complained of some redness and irritation, and certainly a pterygium was present, but there was no attempt to use any medical therapy. And the plaintiff's expert felt that an inadvertent excision of the lateral muscle, was an unacceptable complication. And certainly the secondary surgery, which was required, was also a stress and issue for the patient. And then ultimately, the patient did complain of recurrent and chronic irritation and foreign body sensation. Next slide, please. Now, in the defense expert opinion, basically felt that these types of things should be discussed in advance, and certainly medical treatment is a very reasonable first treatment, and there was no evidence on the patient, on these surgeons' records of any discussion regarding this. I'm not sure if because he was referred to the cornea specialist or why he chose not to, but that's the situation in this case. And then the other experts felt that, you should identify the lateral rectus muscle first, or as much as possible to avoid inadvertent damage, or in this case, a transection of the tendon. And then, of course, the defense expert felt that, and certainly we would agree, a timely referral on the first post-op day to a very reputable strabismus specialist, and he performed urgent corrective surgery, was the right thing to do. Next slide, please. So the claim outcome in this case seems high, and it is high, $375,000. But clearly there was inadvertent laceration of the lateral rectus muscle, did require a secondary surgery, which is, as the patient complained, was stressful and anxiety-inducing, and it did require a longer recovery. It did, according to at least the patient, cause chronic irritation and residual foreign body sensation. And unfortunately, this is a key issue in many of the claims. This is a very litigious venue, and it was thought that rather than try and fight this claim, it was more appropriate to settle. So, certainly things like this can happen, and sometimes they're not preventable, but even in a case that was appropriately referred urgently, you can see the outcome can be, at least in terms of indemnity payment, can be significant, although from a clinical perspective, the patient recovered very nicely. Next slide, please. So the key lessons in this brief case are sometimes, it's easy to say, carefully identify the anatomic landmarks, but many times it's not that easy in the middle of a swollen field. He did recognize the complications early. Now, evidently didn't recognize it at the time of surgery. I'm not sure if he could have, but it would have been nice if he could. However, even if he did, I think we all realize you're not going to go fishing for a retracted tendon in the midst of an office-based setting. It could create significant difficulties, especially with the ocular cardiac reflex and other issues that could come up. And then timely referrals are key, which happened in this case. So as I mentioned, I think it's interesting in some of these cases that although they're handled perfectly appropriately, an indemnity payment is what ends up, just because of the litigious venue and sometimes the particular situations of the case and the claimant. So next slide, please. So I'm going to pass this on to my esteemed retinal colleague, who will be talking about symplasia. We couldn't find a better person to talk about chalazion than Dan. So thank you, Dan, for agreeing to do this.
Thank you so much, Dan. Next slide. Let's go back one. I am a retina specialist, and I will be talking about chalazion surgery. And we already know that chalazion surgery is an established procedure that is routinely done in the office setting already. And we chose to include these procedures because the claims seen can provide some additional teaching points as physicians may decide to transition to more invasive procedures in the office setting. So as already stated, these chalazions are traditionally performed in the office. Over the past 20 years, we've only seen 4 claims. And the local block administered by the ophthalmologist is in all 4 of these claims. And unfortunately, all these cases cause some substantial vision loss. Next slide. So the first case is a 42-year-old man who suffered a central retinal arterial occlusion immediately following the chalazion surgery. And in reviewing the case, the patient had looked down during the administration of the anesthesia. Now, the defense experts felt that the CRAO may have been caused by a possible intra-arterial injection, which is rare, but is a known risk. This would be a challenging case to defend because of the difficulty in trying to explain this complication to a jury. Furthermore, what makes this even more tragic is that the patient was amblyopic in their fellow eye and was now legally blind. The plaintiff attorney was highly demanding to settle and was not willing to negotiate. And as a result, this case had settled just under $1 million. Next slide. The second case is a 11-year-old girl undergoing a chalazion removal who was noted to be restless and difficult when the lid was being anesthetized. Although the child noted vision loss following the procedure, she did not inform her parents until 9 weeks later. On examination at that point, the optic nerve exhibited atrophy with some retinal scarring near the macula. Her vision preoperatively was 20/20 and now was hand motions vision. This case unfortunately could not be well defended, and the experts felt that this child should have been sedated for the procedure. The outcome was that the case was settled for $585,000. Next slide. Next slide, please. Now, case 3 is a 49-year-old who suffered a globe perforation during administration of a local anesthetic. The patient developed a retinal detachment, subsequently developed a PVR, and had redetached again. The defense experts felt that the perforation was the cause of injuries and that this would be a difficult case to defend. Patient's final vision was 2200. Preoperatively, he was 20/30, and the case was settled just under $500,000. Next slide, please. The fourth case is a 35-year-old who reported pain and vision loss on post-op day number 1 following their chalazion removal. Patient was evaluated and referred to a retina specialist who found a large corneal epithelial defect as well as a choroidal retinal lesion, which was consistent with the globe perforation. In reviewing this case, defense experts felt that because of the large size of the chalazion and very tender, that this case needed more anesthetic than usual, which may have prompted the globe perforation. Patients did not have a retinal detachment. However, the final visual acuity was 2200, and the case was settled for $250,000. Next slide, please. So what are some of the key lessons from these 4 claims? Well, first, we must realize that procedures, all procedures, but even procedures that are commonly performed in the office setting, carry risk. And local anesthesia can cause significant complications, as we saw in these 4 claims, that they are very difficult to defend and have all led to settlements. Interestingly, during the discovery process, there were no complaints regarding the outcome of the chalazion removal itself There was no complaints about the lid anatomy postoperatively or any cosmetic defects. These were all related to the local anesthetic complications. And it's very important that we think about criteria such as the patient's age and the anxiety level really need to be carefully considered to minimize such complication risks. Next slide, please. Other things that came up, one is corneal shields. A corneal shield was not used in any of these cases. And it's not even clear if a corneal shield would have prevented these perforations. However, it was brought up both on the plaintiff and defense side, and it should be something that should be considered for select cases. And finally, treatment rooms in the office should mirror ambulatory surgical center rooms. And really, because we want to maximize our visibility in our surgical field, and we want to provide an environment that's very comfortable and not distracting for both the patient and the surgeon. Next slide, please. Well, that concludes my section, and we're going to now have Ann Menke, who's our OMIC patient safety manager, who's going to bring this all together and give us some guidance on how we should be approaching a lot of these potential issues that can come up in office-based surgery. Ann?
To both of you, those were great case presentations, and hopefully those listening can find some things to do a little bit differently to avoid these problems. I'm going to state the obvious, which is that the same standard of care applies regardless of where you're doing the surgery, and that the guiding principle in the decision-making process should be the patient's safety. There are some significant differences between an office and a surgery center or hospital. Surgery centers and hospitals are subject to state and federal licensing requirements, and these are in place to protect patients. There's also usually no peer review or quality review in the office setting, especially if it's a smaller practice. And again, this is another lost opportunity to review cases, learn better practices, protect patients. In the office, you have a much less robust rescue capacity. And if you're the only one there and there's no anesthesia provider, you need to be able to rescue the patient from deeper than intended sedation if you're using that, or address cardiac or respiratory events. And this involves the capability to manage an airway and advanced life support measures that many ophthalmologists probably don't have those skills anymore. In fact, most ophthalmologists have very limited experience doing resuscitation, and there's no code team available. You most likely don't have a full crash cart. If you do have one, which is very rare, you probably don't have current competency to use all the medications in it. One way to decrease the risk and decide if an office is the right place for a patient is the preoperative medical evaluation. We've just posted detailed recommendations on this in a document on our website, and I'm going to go over some aspects of that. We know that surgery and anesthesia are inherently risky. In fact, now there's an acknowledgement that you cannot totally reduce that risk. So the idea of clearing someone for surgery is not used very often. And instead, the goal is to identify the level of risk and optimize the patient's condition before surgery if possible. This is often more important for patients having surgery in the surgery center or hospital, since they might have more complex medical comorbidities. The preoperative medical evaluation also enables you to anticipate potential complications, such as hemorrhage from hypertension, as we saw in some of the cases. And most importantly, this will help you determine where the surgery should take place. The American College of Cardiology and the American Heart Association have several times issued joint guidelines on how to evaluate patients undergoing non-cardiac surgery. And the goal of their guidelines are to determine what risk patients face for cardiac events. When they issued these guidelines in 2014, there were more than 50 million surgeries annually in the United States. And as you can see, 1.4 to 3.9% of these cases involved a perioperative cardiac event. And these complications were the most common cause of perioperative morbidity and mortality. So the guidelines propose a two-pronged approach. One is to evaluate the procedure type, and the other to look at the patient's characteristic. One of the key takeaway points for ophthalmologists is, according to these guidelines, ophthalmic surgery is a low-risk procedure. It's less invasive, there are limited fluid shifts and cardiac stress, and in fact, cataract surgery is one of the two examples given for a low-risk procedure. Dr. Berinstein and I discussed patients who undergo general anesthesia for retinal procedures. This is not happening in the office, but that they're at higher risk because of the general anesthesia and the length of the surgery, not because of the type of the surgery. So the goal, again, is to predict the likelihood of a major adverse cardiovascular event, or MACE. There are several cardiac risk calculators available. I've listed a couple here. Clearly, we do not anticipate any ophthalmologist going online, using a calculator, inputting patient data, and determining the cardiac risk. But I think it's helpful to look at this to get a sense of what types of patients are considered high risk. So let's look at the RCRI calculator. There are 6 characteristics that the physician looks for. We've determined that ophthalmic surgery is low risk, so the other 5 are ones to ask about during the history. Does the patient have ischemic heart disease, heart failure, cerebrovascular disease? Is the patient on insulin to treat diabetes? And is there some amount of renal failure? In this calculator, each of these are awarded 1 point. And you'll notice that even with none of these characteristics, there still is a small risk of a major cardiac event. If you have one of the factors, it's less than 1%. So 0 or 1, that's a pretty low risk situation. However, as soon as you get to 2 or more, as you can see in the third column, the risk climbs significantly. So this leads to the question, who should do the pre-op evaluation? If the patient's risk for MACE is greater than 1%, that is, if they have 2 or more of the 6 criteria, they should be evaluated by a primary care physician, internist, or cardiologist. If you're not asking about those criteria in your history, any ill patient with significant medical comorbidities should also be referred for a preoperative evaluation. Again, the object here is not to clear the patient, but to identify risks and reduce the risk as much as possible. If you have current competency in performing history and physicals and you're comfortable doing them, and the patient has no high-risk conditions, then you can proceed and obtain and document a careful history, review of systems, and then note any positive and negative exam elements. I've spoke with an anesthesiologist as part of this work, and he said he worries the most about breathing problems, especially if the patient has to lie down for the surgery. So he says to ask about COPD, note morbid obesity, which is a proxy for sleep apnea. He said, in fact, any obese patient, you should be worried about sleep apnea. He also recommended checking for orthostatic hypotension, but I don't think that's going to happen in most ophthalmology practices. When have ophthalmologists been sued for their choice of anesthesia? They've been sued if they chose retro or peribulbar blocks in patients with hemophilia, treatable low platelets, deafness, or cognitive impairment, and when they didn't discuss anesthesia options. If we look at our ophthalmic anesthesia claims, there was a study published in Ophthalmology in July. Dr. Michael Morley, Dr. Karen Ninji, and I looked at 10 years of OMIC's ophthalmic anesthesia claims. And in that study, one patient died in the office after receiving a retrobulbar block. The patient was extremely restless. The physician wanted to just perform an A scan before cataract surgery. Other than the physician, there was no other licensed staff. They had limited ability to help the patient. They called 911, but the patient died. Another patient in our study had hemorrhage after retrobulbar block. There were several cases of brainstem anesthesia. And in all the cases presented today, there were significant complications following local blocks. It's really helpful to inform the patient of the type of anesthesia you normally use. Explain why and document why you want this type and not other types. Take into account the patient's history, review of systems, and the exam to determine if the patient is at higher risk for that type of anesthesia, and be sure to discuss these specifically with the patient. We're often asked who should obtain consent for anesthesia. Obviously, if you're the one performing the block, then you have to obtain informed consent for the block. If there are anesthesia providers present, you will discuss the options, but the anesthesia provider will obtain informed consent if they're doing the block and consent for sedation. As you noted in one of the cases, it's really important to determine if the patient is on any anticoagulant or antiplatelet medications because they face a risk of either vision-threatening hemorrhage or life-threatening stroke or heart attack. Discuss your plan with the patient. In a lot of eye surgeries now, these medications aren't stopped. And so that's important to tell the patient and explain that. If you do want to make any changes, we strongly urge you to discuss this with the physician who prescribed these medications before you make any changes. We also feel you should obtain informed consent whether you're continuing or discontinuing the medications, and we have a sample consent form on our website, and you should let the anesthesia provider know what you're going to be doing. A word on hypertension. This is a big problem in a lot of cases, as you saw in one of Dr. Briceland's cases. It leads to enhanced myocardial oxygen demand, can lead to hemorrhage. So our advice is, in the office, delay the surgery or ask anesthesia for guidance if the systolic pressure is between 160 and 200, and the diastolic is above 90 up to 109. But if the systolic is greater than 200 or the diastolic greater than 110, we feel that it's really the prudent thing to do to cancel the surgery and send the patient for immediate treatment. So let's finish with our explicit risk management recommendations. I'm sure you're familiar with the American Society of Anesthesiologists physical status system, and we feel that you should only perform procedures in the office on PS1 and 2 patients if there's a risk of a serious operative complication. So let's review what these are. The examples given are those of the ASA. So PS1 is a normal, healthy patient, non-smoking, no or minimal alcohol use. PS2 are patients who have mild systemic disease, but no substantive functional limitations. So examples given are a current smoker, well-controlled hypertension or diabetes, mild lung disease, and obesity with a BMI between 30 and 40. Patients with PS3 should have the procedure performed in an ASC or hospital if they have severe systemic disease with functional limitations, poorly controlled diabetes or hypertension, COPD, morbid obesity with a BMI greater than 40, or end-stage renal disease on dialysis. Let's address now our recommendations for anesthesia and sedation in the office. We recommend that you provide only minimal sedation and analgesia. This allows a normal response to verbal stimulation and has no impact on the airway, spontaneous ventilation, or cardiovascular function. There are FDA-approved devices called Pronox that can help patients self-administer some medication to relax them in the office, and those are considered safe. Unless you have an anesthesiologist or a CRNA in your office, we do not think you should be providing moderate or conscious sedation. We just don't think it's safe. As the cases presented today show, you need to be prepared to manage complications from blocks, such as brainstem anesthesia, globe perforation, hemorrhage, and CRAO. Finally, here are some resources that will help you. On our website, there's a consent form, as we mentioned, for anticoagulants. There are 2 very detailed recommendation documents, one on office-based surgery and the other on preoperative medical assessments. I mentioned the study of our OMIC claims that was published in July in Ophthalmology. If you have questions about the course or office-based surgery, we encourage you to email us at riskmanagement@omic.com. Dr. Briceland wanted me to make sure and say that he and Dr. Berinstein are happy to ask questions. Please send your question to the risk management mailbox. and ask that to be forwarded to either of the physicians. I want to thank both of my co-presenters who did an outstanding job, and we hope that this was useful for you.